So, good evening, everyone. My name is Davis. So, I'm a fifth year medical student of Karazin. So, I would like to see your faces if that's not too much to ask. Please, can you guys turn on your video? I just want to see who I'm speaking with. So, if I see you on the street next time, I can say hello. Guys, can you hear me?
Yeah, okay.
Okay, thank you. Okay. Okay. So thank you guys. So today's class, we're going to try to make it as interactive as possible. So if you have any questions, you can stop me at any time and ask. And also when it gets to the question section, I'm going to call in each and every one of you one by one to answer some questions. So yeah, let's start. So first of all, we're going to start with some definitions. So we're going to start saying easy. So first, we're going to be starting with general pharmacology. So first, we're going to start with definition of pharmacodynamics. So pharmacodynamics simply means what does a drug do to the body? So basically, it means the effect of the drug. So for example, when you take paracetamol, it's going to help reduce your headache. So what effect does the drug have on the body? That's pharmacodynamics, pretty easy. So next is pharmacokinetics. So what does the body do to the drug? So this means what effect does the body have on the drug? So how does he eliminate it? How does he break it down? So what effect does the body have on the drugs? So that's the first definition, pharmacodynamics, the drug effect on the body, and pharmacokinetic, what does the body do to the drugs? So next we have a receptor. So basically a receptor is a target molecule for a drug. So when you take a drug, it goes straight to the receptor and binds the receptor. So then we have a drug receptor complex. So when the drug and receptor complex come together, it can have three effects. So it can be agonist or antagonist or both agonist and antagonist. So agonist is a positive effect, while antagonist is a negative effect. So agonist increases the action of that receptor, while antagonist inhibits it. While agonist and antagonist has both effects, so it's both positive and negative. So next is combined action of drugs. So this is when you take two or more drugs together. So the first term we're going to talk about is synergism. So this is when you strengthen an effect of a drug. So for example, when you take drug A plus drug B, it's going to create a bigger reaction than when you take each of these drugs separately. So you can see here, 1 plus 1 equals to 3. So drug A plus drug B is going to create a bigger reaction than when you take them separately. So that's synergism. The next is potentiation. So potentiation is similar to synergy, but it's different. So for potentiation, one drug enhances the effect of the other drugs. So drug A is going to enhance the effect of drug B. So you can see here from this reaction, C equals to A plus B. So drug A is potentiating the effect of drug B. Next is antagonism. So this is when it opposes the effect. So it weakens the effect. So it's the opposite of synergism. Okay, so next is accumulation. So this occurs when you take a drug and it accumulates in your body. So there are two types of accumulation, material accumulation and functional accumulation. And what's the difference between material and functional? So for material accumulation occurs when the drug is still in your system, so it hasn't been eliminated. While for functional occurs after the drug has been eliminated. So even after the drug is out of your system, you're still going to feel the effects of the drug. So an example for functional accumulation is antidepressants and also alcohol. So even after you finish taking alcohol, you finish urinating out all the alcohol, you're still going to feel the effects of alcohol. So you're going to be dizzy and you're still going to feel drunk. While for material accumulation is while the drug is yet to be eliminated. So the drug is still in your system. So I want you to pay attention to digitoxin. That is a very important for a question. So when you take too much digitoxin, it becomes accumulated in your system, and then you experience negative side effects. The next one here is tolerance. So tolerance occurs when you take a drug too often, and then you need a higher dose for it to create an effect. So for example, let's say if you have menstrual pain. So every time you take menstrual pain, you take a painkiller. So it's got to a point where you have to take a higher dose for you to help reduce the pain. So that's tolerance. So another name for tolerance is habituation. Then tachyphylaxis. Tachyphylaxis is almost the same thing as tolerance, but only that it's more rapid. So tachyphylaxis occurs within the first day. So after the first day, you have to take a higher dose to see a desired effect. So I want you to take note of the difference between tolerance and tachyphylaxis. So tachyphylaxis is when you need a higher dose within the first day. So it's tolerance that occurs in the first day, while tolerance occurs over a period of days or months. Then the next definition is drug dependence. So this is an irresistible urge to take a drug. So for example, maybe you're addicted to codeine, so you have a strong urge to take the drug. So there are two types of dependence, physical and psychological. So physical is for those who have a physical need for the drug. For example, people who have chronic pain, so they need the drug to take away the pain. But for psychological dependence, there's no physical effect. So they're just taking the drug to alter their mood, to make them feel happy or to take away any stress or to make them just feel relaxed. So that's the difference between physical dependence and psychological dependence. Physical dependence takes away the pain, while psychological is just to increase or to make their mood feel better. Then abstinence. Abstinence is what you feel when you're not taking the drug for a long time. So for example, if someone is addicted to morphine and they are deprived of morphine for a long time, so they are going to get some symptoms of morphine withdrawal. Okay, so that's it for the first topic. So now we're going to have some questions. So when I call your name, just try to read the question and answer. So you have about 1 minute to read and answer. So let's start with Blessing. So Blessing, please read and answer. Blessing, I can see you. Yeah, so Blessing, and turn on your mic, just read and answer.
Okay,
You
so
feel it is fine.
continuous taking of
Mhm.
can you hear me?
Yeah, I can hear
Continuous
you.
taking of drug results in reduction of its efficiency. The phenomenon is called continuous taking of drug dependence.
Try again. So I want you to take note of reduction of its efficiency.
Reduction
So
of its efficiency.
yes.
Tolerance.
Yes, that's correct. So because they said reduction of its efficiency, so the drug is not going to work in effectively. So it's habituation or tolerance. Okay, thank you, Blessing. So next person is Joshua. Joshua, please, can you read and answer the question?
Yeah, a patient has been taking isosorbide for stenocardia prevention for quite a long time. Now he notes a significant decrease in the effect of the drug. What is the phenomenon called? This is called chill, taken for a long time. I'll go tolerance.
Yes, that's correct. So once again, we see a decrease in the effect of the drug. Good job. So next question is this. So, Amin, this is your question.
Well, drug addicts are often a termination of action. Drug have heavy physical and neurological stomach violation. What's the name of this symptom complex? If just the question mentioned the action, the drug of heavy physical and neurological, I think it's a tachyphylaxis.
Okay, so I want us to pay attention to drug addicts upon termination. So this is after the person has stopped taking the drug. So the person experiences symptoms of withdrawal. So when you experience symptom of withdrawal, what do you think it is? So I want you to try again.
Abstinence.
Hudson, we're giving Amin, it's Amin's question. So when it gets your turn, you answer. Yeah. Okay. So
Okay.
Amin, the answer is abstinence syndrome. So abstinence syndrome simply means it occurs in drug addicts. So when they stop taking the drugs, they have symptoms, physical and neurological. Okay. So tachyphylaxis is tolerance that occurs within a day.
Yeah.
Okay, so next person is Timmy. This is your question.
A patient who has been suffering from cardiac insufficiency for several months has been taking digoxin on an outpatient basis. At a certain stage of treatment, there appeared symptoms of drug overdose. What phenomenon underlies development of this complication? Functional cumulation,
Try again.
material cumulation.
Yes, material accumulation is correct. So the difference between functional and material is that for material, the drug is yet to be eliminated from the system. So there's accumulation of drug in your system. So for digoxin, it's material accumulation. Why for drugs like alcohol? So even after you've eliminated the alcohol from your system, you can still get symptoms of overdose. So that's different between functional and material. So if it was alcohol that we're talking about here, so it might not be functional accumulation, but for this question, the answer is material accumulation. Okay, so next person is Agnes.
A patient taking clonidine for essential hypertension treatment was using alcohol that caused intense inhibition of central nervous system. What may it be connected with? Intoxication.
Try again.
Can it be cumulation?
Okay, so that's not correct. So the correct answer here is effect potentiation. So why is this the correct answer? So we can see here the person is taking clonidine for hypertension, and then the person takes alcohol. So alcohol increases the effect of clonidine. I remember we said potentiation occurs when you take two drugs and one drug increases the effect of the other drug. So in this case, the answer is potentiation. Do you understand?
Yeah.
Yes, thank you.
Okay. Next question is for Dauda.
Sorry, which one? The first one, okay.
Yeah, that's one.
As poisoning by can you hear me?
Yeah, we can hear you.
Okay, as poisoning by organic compound and epoxy sulfate was used. What phenomenon is underlying in antidatal action? Um, is
I'm sorry, what's your answer?
it potentiation?
No, try again.
A poison of the and epoxy sulfate was synergy.
No, okay. So the answer here is antagonism. So remember we
But
said
there is no, sorry. Oh, I know that the A was part of the something. Okay.
okay. Oh, you didn't see the A. Ah,
That's
okay.
the
Yeah, so do you understand why it's antagonism? Hello, Dauda? Okay, so it's antagonism because the question says the person was poisoned with forceful organic compound and atropine sulfate was used to reverse the poisoning. So we're looking for the opposites. So we're looking for what drug is going to oppose phosphoorganic compound. So antagonism has to do with opposites. So for agonist, it increases the effect, while antagonism decreases the effect. So atropine is an antagonist or phosphoorganic compound. Please, I want you to take note of this question. It comes out every year. So phosphoorganic poisoning, the treatment for phosphoorganic poisoning is atropine, and the mechanism is antagonism. Okay, so does anyone have any questions? We're moving on to a new topic. Any questions? No?
We've not done the next question.
Okay, next question. So Godson, this is your question. Godson. Okay, so Godson is not with us. So, I mean, try to answer this question.
What's the name of the phenomenon when the prolonged using the preparation, its efficiency goes down? Okay. Adoption tolerance. A prolonged using the preparation efficiency goes down. Goes down is like I try tachyphylaxis, that it goes down. The effect of
So tachyphylaxis occurs in a day. So it occurs very fast. So here we talked about prolonged using of a preparation. So after a long period of time, so maybe months, days, or years.
Addiction.
It's tolerance. Yeah. So
okay.
I want you to pay attention to efficiency. So when the question talks about efficiency of a drug going down, it's either tolerance or tachyphylaxis. The difference is tachyphylaxis occurs within a day, within a very fast period of time, while tolerance takes place within months to years or days, so a longer period of time.
Tachyphylaxis duration so long?
It occurs within a day, within one day,
okay.
within a very short period of time, while tolerance takes longer to occur. So from this question, we can see when a prolonged using of preparation, its efficiency goes down. So the answer is tolerance. Okay, so any questions? So is there anything you guys do not understand clearly? No? Okay, so let's move on to the next topic. So the next topic is cholinergic drugs. So cholinomimetics. So first of all, we're going to talk about the nervous system. So we all know we have the central nervous system, which includes the brain and the spinal cord, then the peripheral nervous system, which includes the somatic and the autonomic. So the somatic nervous system talks about the skeletal muscle and the skeletal system, while the autonomic focus on the sympathetic and parasympathetic. So for cholinergic drugs, we're going to be focusing on the parasympathetic system. So parasympathetic system is rest and digest. So it has to do with the visceral organs, so the stomach, the intestine, and also the heart, the cardiac outputs. So for cholinergic drugs, we're going to be focusing on its effect on the parasympathetic system, so the rest and digest functions. So I want us to take a look at this diagram. So from this diagram, you can see the parasympathetic and the sympathetic divisions. So for the parasympathetic, we can see that the presynaptic neurotransmitter, so this one right here, this is the presynaptic neurotransmitter, and it's acetylcholine. And this is the postsynaptic neurotransmitter. It's also acetylcholine. Then we go to the skeletal muscle. So we can see it's also acetylcholine for the somatic system, but for the sympathetic system, we can see the neurotransmitters are different. So for sympathetic, it's norepinephrine, dopamine, and also epinephrine and norepinephrine. So I want us to take note. So for parasympathetic system, the postsynaptic neurotransmitter is acetylcholine, while for sympathetic system, the postsynaptic neurotransmitter is norepinephrine, epinephrine, and dopamine. So for these drugs, we're going to be focusing on the parasympathetic system. So this and this and this. Okay, so moving on. So we're talking about cholinergic drugs. So next, we're going to talk about, this is the postsynaptic receptor. So here we can see the receptors, and this is the presynaptic membrane. So we can see it releases acetylcholine into the postsynaptic gap, and then acetylcholine binds to the receptors. So I want you to take note of this. So this is called acetylcholine esterase. So what's the function of acetylcholine esterase? So its function is to break down the acetylcholine in the synaptic gap. So it's going to break down acetylcholine so it can be reused back in the presynaptic membrane. So this is very important for krok, acetylcholine esterase. Okay, so moving on, we have cholinereceptors. So these are receptors responsible for acetylcholine. We have 5 muscarinic cholinereceptors: M1, M2, M3, M4, and M5. So muscarinic cholinereceptors has 5 receptors, M1 to M5. So now we're going to talk about the location of these receptors. So I want you to memorize this table. So how I memorize this table is by using a nursery rhyme. So it's head, shoulders, and everywhere else. So M1 is located in the head, so which is the CNS, and then M2 is located in the heart. Then M3 is everywhere else. So the smooth muscles, the bronchial muscles, then the vascular endothelium. So I want you to pay attention to M2 and M3 and M1. So these are the most important. So M1 is in the CNS, which is the brain and the spinal cord, and also in the parietal cells of the stomach. And M2 is located in the heart. Then M3 is located in the exocrine glands, the smooth muscles, and the vascular endothelium. Now, so cholinergic drug has 2 types of receptors, the muscarinic receptors and the nicotinic receptors. So we just talked about the muscarinic receptors, which is from M1 to M5. Now we're going to talk about the nicotinic receptors. So there are 2 types of nicotinic receptors, the NM and the NN. So the NM cholinereceptors are found at the neuromuscular junction. So what's neuromuscular junction? So it's like a terminal between the nerve and the skeletal muscles. So these are the receptors at the terminal between the nerve and the skeletal muscles. So we can see the neuromuscular junction here. So this is the neuromuscular junction. So here the receptor is NM. Okay. So next, the location of the nicotinic receptors. So NM is found in the neuromuscular junction. So NM for neuromuscular, while NN is found in the ganglias. So now we're going to talk about the drugs that act on these receptors. So we have 2 types of drugs that have 2 mechanisms of action. So the direct acting and the indirect acting. So the direct acting acts directly on the presynaptic membrane to increase the release of acetylcholine. So if we take a look at this diagram, so the direct acting is going to act here to increase the release of acetylcholine. Those are one group of drug. Then we have the indirect acting. So the indirect acting is going to act here. So it's going to block acetylcholine esterase. So by blocking acetylcholine esterase, it's going to prevent the degradation of acetylcholine. So by blocking this, there's going to be increase of acetylcholine in this gap. Okay, did you guys understand that concept? Do you have any questions? So the direct acting drugs act here, increasing acetylcholine in the presynaptic membrane, while the indirect acting block acetylcholine esterase, whose function is to break down acetylcholine. Okay, so now we're going to talk about the drugs. So for direct acting cholinergic drugs, we have acetylcholine and pilocarpine. And for nicotinic receptors that act on the nicotine receptors, we have lobelin. So I want you to take note of lobelin. This is a very important krok question. So lobelin's function is to restore breathing. Lobelin restores breathing. Okay, so now we're going to talk about the function of pilocarpine. So pilocarpine can be used to treat glaucoma. So why does it help in glaucoma? Because it decreases intraocular pressure by decreasing aqueous humor production. So if you say a krok question, what drug is used to treat glaucoma, you can say pilocarpine because it decreases intraocular pressure. And other drugs for this, so now we're going to move on to the indirect acting. So we have drugs that prevent the breakdown of acetylcholine. So these are called anticholine esterase. So choline esterase is a substance that breaks down acetylcholine. So these drugs is going to prevent the breakdown of acetylcholine, thereby increasing acetylcholine presence. So the names of the drugs are physostigmine and neostigmine. So neostigmine is also called proserine. This is very important. So there's questions on this every year in krok. So I want you to take note of this drug, neostigmine and proserine. So I want you to just remember that the indirect acting cholinergic drugs end with MINE. So the mines. So they prevent the breakdown of acetylcholine by inhibiting acetylcholine esterase. Okay. So now we're going to talk about the uses of each of this drug. So for glaucoma, we can use pilocarpine. For myasthenia gravis, we can use neostigmine, physostigmine. Then Alzheimer's, we can use galantamine, rivastigmine. Then for post-operative decolorization, we can use neostigmine. So let's talk about the effect of this drug. So when you think about the effect of the drug, I want you to look at this table. So this drug is going to increase the parasympathetic effects. So it's going to cause sweating, and then it's going to cause urination, and then it's going to cause miosis. So what is miosis? Miosis is constriction of the eye muscles, and then it's going to cause bradycardia. It's going to slow down the heart rate, and then it's going to cause lacrimation and loose stool. So this is very important for krok, because they can set a question like organophosphate poisoning. So Nigerians are familiar with when people drink sniper. So this is what happens when you drink sniper. So sniper is an insecticide that contains cholinergic drug. So when you drink sniper, you're going to experience all of this. I want you to memorize this mnemonic: dumbbell. So when you drink sniper, you're going to experience diaphoresis, which is sweating, urination, miosis. So your pupil is going to be pinpoint, very small. And then you're going to have bradycardia, bronchospasm, vomiting, lacrimation, and also diarrhea. Okay, so organophosphate poisoning, this is very important for your question. Organophosphates. So these are found in insecticides. So when you take sniper, you're going to experience these symptoms: dumbbell, so diarrhea, vomiting, nausea. And how do you treat organophosphate poisoning? Use an antagonist of cholinergic drugs. So atropine is a treatment for organophosphate poisoning. So we're going to give atropine and pralidexome. So I want you to memorize this because this is a core question. Atropine and pralidexome is used to treat organophosphate poisoning. Okay, also I want you to take note of this. So some people can go to the forest and see a mushroom and take it. So some mushrooms contain cholinergic effects. So when you take the mushrooms, you're going to experience organophosphate poisoning too. So you're going to have diarrhea, miosis, vomiting. So one popular question in krok is Amanita muscaria. So this is the name of a mushroom. So when you take it, you're going to experience all the symptoms listed here. So I want you to take notes: dumbbells. So this is the effect of cholinergic drugs. So if you don't remember anything, just remember this: dumbbell is the effect of cholinergic drugs. So diarrhea, miosis, bradycardia, lacrimation, diarrhea. Okay, so now we're going to move on to the opposites of cholinergic drugs. So we're going to talk about the drugs that's going to oppose these effects. So these drugs, so if we have bradycardia, so this drug is going to cause tachycardia. If we have diarrhea, it's going to cause constipation. So now we're going to talk about the opposite of these drugs. So they are called anti-cholinergic drugs. So these are drugs that oppose or inhibit the cholinergic system. So it's going to oppose rest and digest. And the most popular drug of this class is atropine. So you're going to see this in your core question for sure. So atropine prevents the action of muscarinic receptors. So it's going to block here. So atropine is going to block the receptors. So acetylcholine cannot act on these receptors. So it's going to cause the opposites. So it's going to cause the opposite of everything listed here. So anticholinergic drugs are going to cause the opposite of everything listed here. So if you have sweating, you're not going to sweat, you're going to have dry skin. If you have urination, you're going to have urinary retention. If you have meiosis, which is constriction, you're going to have mydriasis, which is dilation of the pupil. And if you have bradycardia, it's going to be tachycardia. For lacrimation, you're going to have no lacrimation. Then for diarrhea, you're going to have constipation. So I want you to take note. Atropine opposes the effect of cholinergic drugs. And that's why it's the treatment for organophosphate poisoning. So when you take too much cholinergic drugs, you're going to take what can oppose it, which is atropine. So atropine is going to oppose the effects. Okay, so now we're going to talk about the action of atropine. So atropine stimulates the many centers, blah, blah. So it can cause mydriasis. We talked about it. It's going to cause dilation of the eye pupil. And I want you to take notes. Never ever give someone with glaucoma atropine, because atropine is going to increase the aqueous humor production and increase the intraocular pressure. So this is a very popular krok question. So they can ask you, what drug can you not give to a glaucoma patient? So the answer is atropine, because it's going to increase intraocular pressure when it increases aqueous humor production. Okay, so now we're going to talk about atropine overdose. So atropine overdose, so I want you to just think of the opposite of this. So whenever you think of the opposite of this, those are the symptoms of atropine overdose. So we're going to get dry mouth, difficulty swallowing, dry skin, difficulty urinating, dilated pupils, and also blurred vision. Yeah. So for the treatment of atropine, so we're going to give cholinergic agonist. And for this, we're going to give physiostigmine. And the mechanism of physiostigmine is anti-choline esterase drug. So it's going to prevent the breakdown of acetylcholine in the gap. So it's an anti-choline esterase drug. Physiostigmine is a treatment for atropine overdose. So I remember this question came out in my krok. So they gave us a patient, and the patient had all the symptoms listed here. So they asked us, what is going to be the treatments? So the treatment was physiostigmine, and the mechanism of physiostigmine is anti-choline esterase. So it blocks the action of anti-choline esterase. Okay, so we're going to list some other anti-choline esterase drug. So we talked about atropine, and then scopolamine is a very important drug for motion sickness. This is a very important krok question. I want you to take note. Scopolamine is used to treat motion sickness. And then other drugs like anti-ulcers drug, pyrazipine. So remember we said M1 is located in the parietal cell. So here, M1 is found in the parietal cell. So when you block M1 in the parietal cell, it's going to decrease gastric acid production. So this is good for ulcer patients, because for ulcer patients, when we treat them, we try to reduce the gastric acid production. So when we give pyrazipine, it's going to decrease the production of gastric acid. So pyrazipine can be used to treat ulcers. And then for anti-asthmatic drugs, so we can give ipratropium or tiotropium. This is going to cause bronchial dilation. So remember we said cholinergic drug is going to cause bronchial spasm. So this is the opposite. So it's going to cause bronchial dilation. And we know asthmatics, their airway are getting tighter when they have an asthmatic attack. So giving this drug is going to make the airway become loose. It's going to dilate it. Also, tropicamide. So this can be used for an eye exam. So when an ophthalmologist wants to examine the eye, it's going to put an eye drop of tropicamide, so the pupil becomes bigger, so you can see the eye clearly. So tropicamide can be used for eye examination. Also, anti-Parkinson drugs. So we have benzotropine and trihexyphenidyl. So I want you to take note of this drug, benzotropine and trihexyphenidyl. So it's a very important question. So it can be used to treat Parkinson. Okay, so next we're going to have ganglion blocking agents. So these are drugs that work on the neuromuscular junction. So I hope you remember the neuromuscular junction. This is the neuromuscular junction. So these are drugs that are going to block it. And when you block it, the muscles are unable to receive impulse. So it's going to cause paralysis. So when you block the neuromuscular junction, you're going to get paralysis. Okay, so now let's list some of the neuromuscular blocking drugs. So we have two types. So the non-depolarizing and the depolarizing. So the non-depolarizing are called curare-like drugs. So they are called curare-like drugs because should I show? Okay, I'm sorry for the interruption. So like I said, we have two types of neuromuscular blocking agents. So the non-depolarizing and the depolarizing. So the depolarizing, an example is succinylcholine or diethylenum. So this is a very important drug for krok. Succinylcholine or diethylenum. So this drug works by depolarizing the end motor plate. So when they depolarize the end motor plate, there's going to be impossible for new impulses to arrive. So when you see it in krok, you're going to see this part. So it produces twitching and fasciculations. So when it causes continuous depolarization, so it's impossible for new impulses to cause the muscle to contract. So these are the effect of depolarizing block. So after this, after you inject the drug, it's going to cause muscle weakness and muscle paralysis. So this is for the depolarizing block. Then we have the non-depolarizing block. So the non-depolarizing is called tubercularine. So this is it here, tubercularine, pancuronium, pecoronium. So they end with curarine. So this is the non-depolarizing. So there's no depolarization. So you're not going to see any muscle twitching or muscle contraction. So take note, that's the difference between depolarizing agent and non-depolarizing. But for depolarizing, you're going to see muscle contraction. While non-depolarizing, you're not going to see any contraction. Okay, so I want you to take note of this. Succinylcholine is degraded by pseudocholine esterase or butyrylcholine esterase. So when you inject someone with succinylcholine, so it's going to be degraded by pseudocholine esterase or butyrylcholine esterase. So after some time, the effect of succinylcholine is going to reduce or stop. But some patients have a genetic deficiency of pseudocholine esterase or butyrylcholine esterase. So for example, if I'm to say I want to make someone paralyzed for surgery, so I inject them with succinylcholine. So normally, after 1 hour, they're supposed to wake up and regain usefulness of their muscles. But for people with a genetic deficiency of pseudocholine esterase or butyrylcholine esterase, they're not going to wake up after 1 hour. So you're going to continue being paralyzed after 1 hour because succinylcholine has not been degraded by butyrylcholine esterase. So I want you to take note, this is a very important question for krok. So deficiency of pseudocholine esterase or butyrylcholine esterase is going to increase the effect of succinylcholine. So indications for this drug for neuromuscular blockers. So these are used for general anesthesia. So when you're going to do surgery, they're going to give you neuromuscular blockers. Okay, so that's all for cholinergic drugs. So do you guys have any questions? No? Okay, so now I have questions for you. Okay, yeah, Agnes, you can ask.
Wait, so please, can you expatiate more on the this slide 43 that talks about the to something? Yes.
Okay, so there are two types of neuromuscular blocking agents, depolarizing and non-depolarizing. So for depolarizing, we have diethylenum and succinylcholine. So when you inject a patient with succinylcholine, normally it's supposed to be breakdown by a substance in the blood called pseudocholine esterase or butyrylcholine esterase. So krok uses both of them, so they might change it anyhow they like. So after you inject a patient with succinylcholine, so it takes 1 hour for this to break down succinylcholine. So, but some people, they have low amount of pseudocholine esterase. So it takes longer for them to break down succinylcholine. So if they go for a surgery, so normal people, it's going to take 1 hour for them to recover from paralysis. But people with genetic deficiency of sodium esterase, it can take 5 hours or 10 hours.
Oh,
Yeah. So for a krok question, they're going to say, I want you to read this part. So in the patient with succinylcholine causes prolonged blockade, resulting in muscle paralysis lasting for hours.
okay.
Do you understand?
Yeah, that means they don't have
Enough
enough
pseudocholine esterase or
choline.
butyrocholine esterase.
Yeah.
Yeah. Okay.
Thank you.
So does anyone have any other questions?
Yeah. So what category of patients are we using like this type of drugs for? So yeah, that's one question. And again, you said the depolarizing agents, right? They cause like a period of
Contraction.
vacillation. Yeah.
Yeah.
Before they actually stop what exactly? Before they cause what? Like what did they do exactly?
They cause paralysis basically.
So you use it for which type of patient? Overactive patient.
So we use it for general anesthesia. So when you're going to undergo general anesthesia for surgery, so we want all your muscles to be paralyzed.
All right.
Yeah.
Makes sense.
Okay. So you also mentioned very important thing. So this is a very important thing for krok. So for depolarizing, so krok is going to mention there's fasciculations or twitching or contraction. So they're going to ask you which drug was it. So it's either diethylenum or succinylcholine. Non-depolarizing drugs like subaquarin do not cause contraction or twitching or fasciculation. So I want you to take note of that. Okay, so question time. So Agnes, your question.
At poisoning by phosphoorganic compound, an atropine sulfate was used. What phenomenon is underlying in antidotal action? That would be
Just answer. Nobody's going to beat you.
B.
Try again.
Can it be antagon?
Yes, that's correct. That's correct. So let's take note of each of them. So synergism occurs when you give drug A and drug B. So drug A plus drug B is going to create a great effect than when you give them individually. While antagonism occurs when you have, how will I put it? Let's say sun and rain. So they're always fighting each other. So they oppose each other. So here we can see that there's phosphoorganic compound. So we're asking which drug is going to treat phosphoorganic compound poisoning. So atropine was used. This is a very important question for krok. It comes out every year. So what drug is going to treat organophosphate poisoning? So the answer is atropine. And what mechanism is this? So it's antagonism. So they oppose each other. Okay, next question. This, I mean,
When copying the instruction to the clinic user, atropine sulfate in section side effects, and student noted tachycardia, increase of the blood, and ocular pressure, temperature rise, and what typical side effect was missed? Atropinic. Nose or vomiting, excessive sweat. Now we have sweat. Dry mouth, eh?
yes, that's correct. Good job. So remember the mnemonic dumbbells. So cholinergic drug is going to cause dumbbell to diarrhea, lacrimation, sweating, while atropine is going to oppose the dumbbells. So the opposite of dumbbells.
Urination.
Yeah, that's correct. Okay, next. Joshua, your question.
Yeah. A child has accidentally drunk a solution that was used by his grandmother for glaucoma treatment. The solution turned out to be pilocarpine hydrochloride. What drug can be used as an antidote? Answer being atropine. It's an anticholinergic.
Yes.
So yeah.
Yes, that's correct. Atropine is anticholinergic drug, not anticholinesterase.
Yeah. Sorry about that.
Okay, good job. So next is Winnie. Winnie, can you answer the next question?
Okay, recommend patients with glaucoma preparation from a group of patients with glaucoma. So I think pilocarpine.
Yes, that's correct. Okay, good job. So next question is for Beauty. Beauty, please answer the next question.
That's which one? 3.
Yes. Yeah.
Patient with glaucoma was prescribed pilocarpine hydrochloride to decrease pressure. What pharmacological group does this medicine belong to? A. M-cholinomimetic.
Yes, that's correct. Timmy, next question.
Name the drug that causes meiosis and lowers intraocular pressure. Atropine sulfate.
Try again.
Pilocarpine hydrochloride.
Yes, so atropine sulfate actually does the opposite of what's here. So yeah, the correct answer is pilocarpine hydrochloride. So that's why it's used for glaucoma. So in glaucoma, there is too much intraocular pressure. So we're going to try to reduce it. So pilocarpine reduces intraocular pressure. Okay, next question. Lesson, are you there?
Yeah, so for the patient of 53 years old, glaucoma is diagnosed. For treatment, the doctor prescribed anticholinesterase medicine as eye drop. Name the drug. I think Preserine.
Yes, that's correct. Good job. Next is Dauda. This question.
What should one prepare to suppress intestinal edema in post-operative period? Protein.
Yes, that's correct. Good job. Okay, next question. Amin left. Yeah, Amin, your question.
Okay. A patient with a dry mouth, photophobia, and blurred vision has been delivered to the emergency department. Objectively, the skin hyperemic dry, and present. He was being diagnosed with the which drug should be given in the antibiotics and nestogymi. Okay. Okay, it's has been diagnosed with alkaloid intoxication. The diproxim E.
Try again. Okay, so I want you to pay attention to the symptoms. So what does the symptoms look like? Pay attention to the symptoms. Okay, so what do you think?
Tachycardia present.
Okay, so I'm going to give you a hint. So the patient is suffering from atropine-like drug overdose. So he's suffering from an anticholinergic crisis.
Yes.
Okay, so what do we give to increase the amount of acetylcholine? So the patient has anticholinergic crisis. So what drug here is going to increase acetylcholine?
Atropine.
Atropine is going to decrease acetylcholine. So the symptoms here are for atropine overdose. So we said atropine is going to cause dry mouth, tachycardia. So now we're going to ask what drug is going to oppose the effect. So what drug is going to cause bradycardia, wet mouth? So the answer is A, neostigmine. So neostigmine is an anticholinesterase drug. So it's going to increase the amount of acetylcholine available. So it's going to cause dumbbells, remember? Diarrhea, urination,
Yes.
lacrimation, meiosis. Yeah. So the answer here is neostigmine. Okay. Next question. Okay, Timmy.
Yeah.
Yeah, your
And
question.
inter-hospital pharmacy.
Mm-hmm.
Okay. An inter-hospital pharmacy got an order from a surgical department for depolarizing muscle relaxants for surgical intervention. What drug was ordered? That would be dicyclinium A.
Yes, that's correct. Good job. Okay, yeah, this question is important. Okay, so Joshua.
All right. During an operation, a patient got injection of muscle relaxant, diethylene, relaxation of skeletal muscles, and inhibition of respiration. Lasted 2 hours. The condition was caused by the absence of the following enzymes. Enzymes. The answer is I think A.
Yes, that's correct. So I want you guys to pay attention to these questions because from this topic, there are some questions that might come out every year. So this is one of them, butyryl esterase or pseudocholine esterase. Also, I want you to understand this mechanism properly. This one, where is it? 1 second. Yeah, this one. I want you to understand this properly because this question comes out every year. So because the patient has dry mouth, tachycardia, so this is a symptom of anticholinergic overdose. So the drug we're going to give is a drug that's going to oppose anticholinergic action. So for here, we're going to give neostigmine. So because neostigmine is going to increase the acetylcholine, but also they can twist the question to give you for cholinergic crisis. So for cholinergic crisis, the symptom is going to be wet mouth, meiosis, bradycardia. So for that, we're going to give atropine. So I want you to understand this question in particular and how they can twist it. It's very important. So does everybody understand this question? Or is anyone still confused?
Yeah, no, I'm having a bit of problem with this question. So like, how can we differentiate? I think both neostigmine and pilocarpine, right, they stimulate secretion of ACH, acetylcholine.
Yes. Yeah, but
Right.
pilocarpine is short acting. So pilocarpine will not overturn the effect here. So you have to give a one that is very powerful. So neostigmine is more powerful than pilocarpine here.
All right.
Okay, so yes, so for this, I want you to remember this table. So this table is very important. So effect of cholinergic drug, dumbbell. So if you don't remember anything from this class, just remember dumbbell. So it's the effect of cholinergic drug. So it causes sweating, urination, meiosis, bradycardia. Bradycardia is very important. So for that question, we had if opposite of this. So when we talk about the opposite of this, we're talking about anticholinergic drug effect. So the anticholinergic drugs we're talking about is atropine. So if we have atropine overdose, we're going to have dry mouth and tachycardia and mydriasis. So please take note of this. It's very, very important. Okay, we're moving on to a new topic. So we're going to talk about adrenergic drugs now. So for adrenergic drugs, we're going to be focusing on the sympathetic system. So this part of the peripheral nervous system. So the sympathetic nervous system. So the neurotransmitters we're going to be dealing with here is norepinephrine, epinephrine, and dopamine. Okay, so sympathetic system we all know is flight or fight response. So some of the receptors of the adrenergic system. So we have alpha and beta receptors. So for the alpha receptors, we have two, alpha 1 and alpha 2. For the beta receptors, we have three, beta 1, 2, and 3. This is very important. Then the location of the receptors. So this table explains the location of the receptors. So for this, it's very important for you to know alpha 1. So alpha 1 is present in the arteries, so in the blood vessels. Then beta 1 is present in the heart. You have to remember it. Beta 1 is present in the heart. Then beta 2 is present in the blood vessels. Then alpha 2 is also present in the presynaptic membrane. Okay, so I want you to take a look at this diagram. So this is a diagram of the postsynaptic membrane. So here we can see the noradrenaline. So the noradrenaline is going to affect either the alpha receptor or the beta receptor. So this is the target organ. So noradrenaline is degraded by COMT or MAO. So these two are going to be very important in the future. So I'm going to tell you about them later. So I just want you to take note of the neurotransmitter here. It's noradrenaline, and it can affect either the alpha receptor or the beta receptor. Now we're going to talk about the action of alpha adrenal receptors. So these are positive effects of drugs that have on alpha receptors. So if you give a drug that has a positive effect on alpha receptors, so alpha 1 is located in the blood vessels and also the eye and also the GIT and the uterus. So on the arterioles, which is the blood vessels, it's going to cause contraction. So it's going to increase the PP. So technically, it can be used to treat hypotension. So when your blood pressure is low, you can give alpha 1 agonist to treat hypotension. So an eye, so on the eye, it decreases aqueous secretion and causes mydriasis. So alpha 1 agonist can be used to treat glaucoma. So remember in glaucoma, we have a problem of excess aqueous humor. So this can be used to reduce aqueous humor production and treat glaucoma. Also, it has effect on the uterus, so it causes contraction. Okay, so moving on to beta adrenal receptors. So I want you to remember beta 1. Don't forget beta 1 is in the heart. So agonist of alpha 1 receptors is going to increase heart rates, increase the force, and increase the velocity. And beta 2 receptors are in the lungs. So it's going to cause bronchodilation. This is going to be very good for asthmatics. So when people have asthmatic attack, they have bronchoconstriction. This is narrowing of the bronchi. So when you give drugs that act on the beta 2 receptors that are agonists, it's going to cause bronchodilation. So it's going to make the bronchi bigger. Okay. So next we have some of the drugs. So we have the direct acting and the indirect acting. So for the direct acting, we have several drugs like noradrenaline, phenylephrine, dobutamine, dopamine, and also non-selective. So I want you to pay attention to non-selective. So the key drug for non-selective is isoprenaline. So you cannot, so isoprenaline is a key drug here. And also for indirect acting, we have ephedrine. So I want you to pay attention to ephedrine can cause insomnia. This is a very popular krok question. It comes out regularly. So ephedrine can cause insomnia. So when you see a drug that taken that gives you insomnia, so you know it's ephedrine. Okay, so this is like a table to make you understand the adrenergic drugs well. So we have drugs that are adrenergic agonists. So they have positive effects on adrenergic receptors. So we have the direct acting, indirect acting. So direct acting can be selective. Selective means they either attack the alpha 1 or the beta 1. So for selective, we have phenylephrine, which is alpha 1. Then for alpha 2, we have clonidine. For beta 1, we have dobutamine. Then for non-selective, we have isobutynyl, epinephrine, and norepinephrine. The mixed acting ephedrine, then the indirect acting. Okay, so I want you to remember the effect of drugs on the receptors. So for arterioles, it causes contraction, so it increases the BP. So it can be used to treat hypotension. Then it also decreases aqueous humor production, so it can be used to treat glaucoma. Then for the beta receptors, it causes bronchial dilation, so it can be used to treat asthma. It also causes increase of heart rate, force, and conduction velocity, so it can be used to treat bradycardia. Okay, so now let's move on to questions. Okay, so for questions, let's start with Dauda.
A patient after breasting had angioedema. Which drug should be immediately injected to eliminate these conditions? I think epinephrine hydrochloride.
Yes, that's correct. Good job. So epinephrine is a drug of choice for anaphylactic shock. Okay, next question, Agnes.
A patient has anaphylactic shock developed after a vaccination. Name the preparation of choice in such a case. Name the preparation of choice. Adrenaline hydrochloride.
Yes, that's correct. Good job. Joshua.
All right. A man develops cardiac arrest due to thoracic trauma. Name the drug that should be introduced into the cavity of the left ventricle. In this case, he developed cardiac arrest. The same, adrenaline hydrochloride.
Yes, that's correct. Timmy, your question.
A patient suffering from allergic rhinitis was prescribed ephedrine in form of nasal drops. The patient has significantly benefited from nasal instillation, and this stimulated him to use the drug every 2 hours. But under these conditions, the drug appeared to be ineffective. What is the most likely cause of this phenomenon? Idiosyncrasy?
Try again.
Drug dependence.
Try again.
Formulation.
Okay, so I want you to pay attention to this. So the drug became ineffective. So after he took the drug, so the person developed like tolerance to the drug. So the drug became less effective. Tell me, what do you think? So the drug became less effective after some time, after a period of 2 hours.
Not sure.
You already said 3 options already. Okay, so it's tachyphylaxis. Yeah, so basically after the person took the drug, so he needed a higher dose for it to become effective. So you can see here that the drug became less effective within a very short period of time. So remember we talked about tolerance and tachyphylaxis. So tachyphylaxis occurs within a short period of time, while tolerance occurs within a longer period of time, from days to months. So in this situation, the person took ephedrine, and after a short period of time, the dose became ineffective. So the answer is tachyphylaxis. Okay, so idiosyncrasy means like unknown. So when the cause of something is unknown. So yes. Okay, next. Yeah. Hello? Okay,
A patient, I'm here.
don't worry about that question. So yeah, that's the end of this topic. So does anyone have any questions on this? So if no, we're going to move on to anti-adrenergic drugs. So basically,
sorry.
yeah.
Please, can you answer the question that you said I should not worry about?
This?
Yeah.
It's this subtamol. That's a subtamol. Yeah. So it's a beta 2 receptor agonist. So it's going to cause bronchodilation. Okay, so next is anti-adrenergic drugs. So these are drugs that are going to oppose the adrenergic effects. So here we have beta blockers. So these are drugs that are going to block the beta receptors. So we have selective and non-selective. So the main thing you should remember about these drugs is that they are LOLs. LOL. So whenever you see LOL, know that it's a beta blocker. And then we have mixed one, the drugs that affect both alpha and beta receptors. So cannabidiol and labetalol affect both alpha and beta receptors, while the other ones affect only beta receptors. So what are the main effects of beta blockers? So they can be used for hypertension, arrhythmia, angina, and anxiolytic effect. So take note of anti-anginal effects. So this is a popular question. Okay, so now we're going to talk about antagonists. So the popular alpha-1 receptor antagonist is prazosin and doxazosin. So indications, they are used to treat arterial hypertension. Also, alpha-2 receptor antagonist clonidine, they're used to treat arterial hypertension. So pay attention to those drugs, prazosin, doxazosin, and clonidine. They're both used to treat arterial hypertension. Okay, so yeah, questions? Timmy?
Sorry, please, could you go back to
This?
yeah.
Okay. Okay, so question 1. Timmy, are you ready?
Okay. A patient with essential hypertension. A patient with essential hypertension, the drug from non-selective beta adrenoreceptor antagonist was prescribed. Name this preparation. Prozarin.
No, try again. Wait. What's the mechanism of action of Prozarin? We talked about it earlier. Prozarin is a cholinergic drug. Do you remember the mechanism of action of Prozarin? So another name for Prozarin is neostigmine. So it's an indirect acting cholinergic drug. So it prevents or inhibits acetylcholinesterase. So now we're talking about adrenergic drugs. So it's like a different thing entirely. So we're talking about drugs that act on the adrenoreceptors. So try again.
Prazonin.
What?
Prazonin.
No. Okay, so here we can see that prazosin works on only the alpha-1 receptor. While here, in this part, we can see the beta blockers, so the non-selective ones. So we can see here non-selective ones are atenolol, propanolol. So anaprylene is non-selective. So it works on both beta-1 and beta-2, but it doesn't work on alpha receptors. So the answer to this question is anaprylene. So anaprylene is also called propanolol. So this is a very important question. So propanolol is a non-selective beta adrenoreceptor antagonist. So it works on both beta-1 and beta-2 receptors. Prazosin works on only alpha-1 receptors. So it's going to cause hypertension. It's going to increase the blood pressure. Proserine is an anti-cholinesterase drug, while adrenaline is a adrenoreceptor agonist, while labetalol works on both alpha and beta receptors. Okay, next question, lesson.
Okay, I can't see.
Sorry.
Okay. So a patient with angina pectoris, metoprolol was described. What pharmacological effect of the preparation is used for treatment of angina pectoris? I don't know.
Okay, so what's angina pectoris? You know? Does anyone know what angina pectoris is?
Yeah, like
It's like pain problem.
Like
Yeah,
chest
so
Like
it's
chest pain, something like
yes,
that.
correct. So it's chest pain. So basically, metoprolol is going to stop the chest pain. So drug for treatment of angina is anti-angina, so anti-chest pain. You guys get? Okay. So remember we talked about the use of beta-adrenergic drugs here. So these are the main effect of beta blockers. So it's antihypertensive, antiarrhythmic, and anti-angina. So this question was basically asking you the mechanism of action. So here is anti-angina. Okay. So next question, Joshua.
Yeah. Indicate the state in which non-selective beta blockers are contraindicated. Blockers. Asthma, bronchial asthma.
Okay, yes. Yeah, correct answer is asthma. So this is because for beta 1 receptors are located in the heart, while beta 2 receptors are located in the lungs, in the bronchi. So if you block them, it's going to cause bronchoconstriction in the bronchi. So if a patient has asthma and then you constrict, you narrow the bronchi further, so the person might have respiratory failure. So in asthma, it's absolutely contraindicated. So you never give non-selective beta adrenal blockers for asthma patients. Okay, next, Dauda.
Patient with bronchial asthma was taking tablets causes insomnia headache. What medication was this? I think is Ufilin.
Try again.
Oh, ephedrine.
Yes, that's correct. So the key word here you should look for is insomnia. So ephedrine causes insomnia. That's all. Okay. So does anyone have questions on that topic? No? Okay. So now we're moving on to neuroleptic and anxiolytics. So for anxiolytic, the most popular drug here is benzodiazepam. So benzodiazepam acts on the GABA. So GABA is an inhibitory neurotransmitter. So if too much GABA, you're going to have sedation. Or if there's too little GABA, you're going to have insomnia. So GABA has to be properly balanced. So if there's too much, you have insomnia. If there's too little, you have hyperactivity. So you have excess, you have mania basically. Okay. So the main drug.
Sorry, please, can you repeat what you said again?
Okay, so GABA. So GABA has to be in the middle. So if there's too little GABA, you have insomnia. So because GABA is an inhibitory neurotransmitter, so when the inhibition is less, there's hyperactivity. So less GABA leads to hyperactivity, but too much GABA causes sedation. So sleepiness, amnesia. So you become less excited. Do you get?
Yes, thank you.
Yeah. Okay, so the main drug here is benzodiazepam. So I want you to remember benzodiazepam end with PAM. So they can twist it anyhow they like. Gidiazepam. Gidiazepam is a popular question for krok. Gidiazepam, diazepam. So PAM is benzodiazepine. Okay, so here, so it's going to act on the GABA receptor. So it's going to enhance the effect of GABA. Remember, GABA is an inhibitory neurotransmitter. So it's going to increase the frequency. And I want you to take note of this. If there's benzodiazepine overdose, the drug of treatment is flumazenil. So this, flumazenil is an antagonist from benzodiazepine overdose. This is a popular krok question. So remember this. Flumazenil is used to treat benzodiazepine overdose. Okay. So these are the effects of benzodiazepams. So it's an anxiolytic, anti-anxiety, hypnotic. So hypnotic means relaxant or sedation. And anticonvulsants. So we all know how it looks like when someone is having convulsions. So it can be used to treat convulsion or cease convulsion. Okay, so questions. So does anyone have questions so far? Any questions? No, okay, question 1. Beauty.
To a patient who is suffering of a neurosis with anxiety and fear, a doctor prescribed diazepam. What pharmacological effects of preparation allows to use it for treatment of this disease? Anxiolytic.
Correct. Good. So the person has anxiety, so you're going to give an anxiolytic drugs. Yeah, Agnes.
Woman asked to doctor with high irritability, restlessness,
Sorry.
sensibility. Patient was prescribed 30 medicine from tranquilizers. That's it.
Yes, that's correct. Good job. Okay, Winnie, this is your question.
A patient of 30 has synopathy and disequilibrium. Psycho-emotional sphere was prescribed diazepam. What is the cause of psychosedative effects of the medicine? I think activation of the GABA system.
Yes, that's correct. Good job. Next lesson.
A woman suffering from neurosis has disturbed sleep. What drug is optimal for insomnia treatment? So that would be nitrazepam.
Yes, good job. So I want you to take notes. So benzodiazepam end with palm. So anyway they twist it, just so that palm is benzodiazepam. Okay, so next we have antidepressants, mood stabilizers. So this drug is for people with depression. So, and we know the main pathogenesis of depression is when there's low levels of norepinephrine, serotonin, or dopamine. So the main drug here you have to take note of is this, tricyclic antidepressants. So the key drugs here are amitriptyline, imipramine, or nortriptyline. So these are popular questions that will ask you every time. So what drug you use to treat depression? Amitriptyline, straightforward. Okay. And then also we have other classes of drugs, selective SSRIs. So these drugs are also going to treat depression. So examples is the citalopram or fluoxetine. So take note of this, fluoxetine is a popular question. Okay, so moving on. So the effect of overdose of tricyclic antidepressants. So they have similar atropine-like effects, so anticholinergic symptoms. So we're going to have dry mouth, urine retention, increased ocular pressure. So just assume you have atropine overdose. So that's how tricyclic antidepressant is going to look like. Okay, so yeah, so questions. Who's going to answer first? Agnes.
A patient with depression has been administered a drug from the group of tricyclic antidepressants. Specify these drugs.
Yeah, amitriptyline. So drugs used to treat depression are either amitriptyline or imipramine or nortriptyline or fluoxetine. And the mechanism of action is monoamine reuptake inhibitors. So monoamine breaks down norepinephrine. So this is going to block the breakdown of norepinephrine. So when it blocks the breakdown, there's more norepinephrine for the body. So next question is this. So, lesson.
Antidepressants can increase the concentration of catecholamine in the synaptic cleft. What's the mechanism of action of the drug? So that would be inhibition of monoamine oxidase.
Yes, that's correct. Good job. Okay. Next, the same thing. Okay. Okay. So mood stabilizers. So for mood problems, we have bipolar disorder. So bipolar disorder is either there are two spectrums. So you have mania or depression. We all know how depression looks like, but mania is a state of insomnia. So mania is a state of hyperactivity when you're restless. So the drug for mania is lithium salts. It's quite straightforward. So drug for prophylactic and treatment of mania. So mania is hyperactivity. So you are restless, you cannot sleep. That is mania. So the drug for treatment of mania is lithium salts. Okay. Agnes, question.
What group of drugs is used for the treatment and prevention of manias? That will be lithium.
Yeah, lithium, that's correct. So quite straightforward. So whenever you see treatment of mania, it's lithium. Okay, next is nootropic drugs. So these are cognition enhancers. So the key drug here is paracetamol. Paracetamol. So paracetamol increases cognitive ability. So it enhances your learning and memory. So if you take paracetamol now, you'll be able to, if you were reading 5 hours before, you'll be able to read 10 hours. So you're going to increase your ability to learn and memorize. So indications for paracetamol use is Alzheimer's. So Alzheimer's are people that are forgetting memories and also mental retardation and learning problems. So these are people that are kids that find it difficult to learn, and also cerebrovascular accidents. So this is for people that have had head trauma. So when you're involved in a car accident and then you hit your head or something. Also to reduce impairment of consciousness after brain trauma. Yeah, similar thing. So take note, paracetamol is a cognition enhancer. So you're going to improve your brain function. Okay. Winnie. Winnie.
A patient after craniocerebral trauma has been prescribed paracetamol. What pharmacological group does it represent? Antipsychotic.
Try again.
Um,
Winnie, try again.
yeah, nootropic agent.
Yes, that's correct. So we can see here, paracetamol is a nootropic drug. Okay. Moving on. So we have anti-epileptic drugs. So we all know what epilepsy is. So it's for people that have like regular seizures where they convulse and they shake violently. So yeah, that's epilepsy. So epilepsy is an excess depolarization of cerebral neurons. Uh, so some of the drugs, they have a lot of drugs for treating epilepsy. So I want you to take note of phenobarbital, sodium valproate, and diazepam. So these are very popular questions. So we have phenytoin, phenobarbital, etosoximide, sodium valproate, diazepam. So I want you to take note of all of them. These are very popular anti-epileptic drugs. Okay, so mechanism of action. So it enhances GABA synaptic transmission. So remember I said it's excess depolarization. So GABA is an inhibitory neurotransmitter. So when you use this drug, it's going to activate GABA and GABA is going to suppress depolarization. Okay, so questions. Dauda.
An attack of general tonic-clonic convulsion accompanied by loss of consciousness and general suppression of the CNS developed in patient after trauma. What drug should be used? Phenobarbital.
Correct. Next, Beauty.
A patient with convulsions was delivered by the ambulance to the hospital where the diagnosis of status epilepticus was given. Indicate the drug of the first choice in this situation. Phenobarbital.
Try again.
Diazepam.
Yes, correct. Okay, so I want you to take note of this question. It's quite tricky. So phenobarbital and diazepam is used to treat epilepsy. Both drugs can treat convulsion, but for status epilepticus, the drug of choice is diazepam. Please take note. So status epilepticus means prolonged epilepsy. So normally epilepsy is supposed to last for, so seizure is supposed to last for less than 5 minutes. So when it's more than 5 minutes, then it's status epilepticus. So the drug of choice for seizures that last for more than 5 minutes is diazepam. Okay, next question. Joshua.
Yeah. A patient with epilepsy and depressive reaction has been administered a drug that reduces epilepsy manifestation and improves the patient's psychic condition. Phenobarbital.
Try again.
Then sodium valproate.
Yes, that's the correct answer. So this is like a tricky question because phenobarbital can also be used to treat epilepsy. But the main thing here is the patient's psychic condition improved. So for that, the drug of choice is sodium valproate. So sodium valproate can improve the psychic condition, but phenobarbital cannot. So take note of this question because it can be quite tricky. Okay. So next disease we have is Parkinson. So Parkinson is caused by lack of dopamine. So when the brain has too little dopamine, it can cause Parkinson. So the main treatment for Parkinson is levodopa and carbidopa. So what is levodopa? So levodopa is a dopamine precursor. So when you take levodopa in the brain, then something in the brain converts it into dopamine. So that's what the precursor means. So it comes before dopamine. Then carbidopa prevents the peripheral metabolism of levodopa into dopamine. So the only place we want levodopa to be working is the brain. So, but when you give it into the body, it can work everywhere. But carbidopa prevents the levodopa from working outside the brain. So carbidopa prevents the peripheral metabolism of levodopa into dopamine outside the brain. Okay, so that's pretty straightforward.
Question.
Yeah.
Do you use levodopa and carbidopa together, or you use them like?
Yes, use it together. It's a combo drug.
All right.
Yeah. Okay. Blessing.
What preparation should be prescribed to treat Parkinson's disease? Levodopa.
Yeah, that's pretty straightforward. Okay, next topic is anti-angina drugs. So angina, like we said earlier, is chest pain. So anti-angina drugs is anti-chest pain drugs. So what drugs are we going to give when someone has chest pain? So the drugs are nitrates, calcium antagonists, and beta blockers. So I want you to take note of nitrates. So this is the most popular drug for chest pain. So nitrates are taken sublingually. So the examples of nitrate are isobutide dinitrate, isobutide mononitrate, and nitroglycerin. So they cause vasodilation and is going to reduce chest pain. Also, calcium antagonist example, rapamycin, diazoxime, nimodipine, then the beta blockers. So the laws, all the laws are going to help you reduce chest pain. So I want you to take note, nitrite is taken sublingually, so under the tongue. So examples are nitroglycerin, isobutide dinitrate, and isobutide mononitrates. Okay, so questions. Beauty.
Okay. For rapid relief of symptoms of stenocardia, a patient takes nitroglycerin in capsules. What is the most rational route administration for this preparation? Sublingual.
Correct. Dauda, next question.
A patient who have ischemic heart disease was prescribed a sublingual medication, nitroglycerin.
Correct. Okay, next question. Lesson.
To the patient suffering on the attack of stenocardial drug from group of nitrates prescribed, name the preparation. Group of nitrates. That would be A.
Correct. Good job. Joshua, next question.
Yeah. After a long-term intake of isosorbide to prevent anginal attack, the patient noticed significant effect of the lash. What is the name of this phenomenon? Oh yeah. The lash accumulation.
I'm also confused. What the hell is lash? I think I read the wrong thing. 1 second. Okay, so it's actually supposed to be a significant decrease of its action. Do you guys get it? So there's a significant decrease of its action. Joshua, you hear me?
Yeah. So a patient noticed significant increase of its action. So can it be potentiation?
Decrease of its action.
Increase of its action.
Decrease.
Oh, decrease. Tolerance.
Yeah, it's tolerance. So decrease of its action after a long-term intake is tolerance. It's quite straightforward. Okay, good job, guys. So last question is for Agnes.
Indicate the nitroglycerin drug with prolonged action. Sustac.
Yeah, that's correct. Sustac is a nitroglycerin drug. Okay, so that's the last slide for today. We're done. So does anybody have any questions?
No, not really.
Okay, so thank you guys for attending today's class. Today's a class tomorrow by 4 p.m. till 6 p.m. So I hope to see you guys there. Okay, so if no one has any questions or anything to say, that's the end of this class. You can have a nice day. Good night.
Thank you very much.
Thank you very much.
You're
Thank you.
welcome.
Thanks, boss.
Thank you.
Okay. You're welcome. Good night, guys. See you tomorrow.